Hey everybody, welcome back to Poem Peeps. We are back after taking a brief hiatus to rest and recover after ATS. It was an awesome conference, but I feel like I just got back on my feet afterwards. Maybe our guests can share our same experience, but it's awesome to be back with a great episode I'm looking forward to. Hey Monty, how are you doing?
Hey, Farf, doing well. I know, I feel like I needed a few weeks for the social battery to recharge.
Sure.
But really excited to be back today, and I think we're going to have a fantastic episode. And today we're going to be talking about pre-oxygenation methods for endotracheal intubation and the PREOXI Trial, which is hot off the press in the New England Journal of Medicine, and for the potentially widespread practice changing results. I feel like this is the talk of the town amongst PCCM, I think, nationally and internationally. And we're so lucky to be joined by two of the authors of the trial. So first, let's meet our guests.
Yeah, absolutely. Before we begin, I'm just going to comment. This is the first episode where we're actually recording video as well. This should be available on ViewMedi and YouTube. If it's not, it's because we messed something up, and don't hold me to this. But if you're interested in watching us talk about this, then you should be able to check it out there. But now let's dive in. So first we have Dr. Kevin Gibbs. Kevin is an associate professor of medicine at Wake Forest University School of Medicine. He obtained his MD at George Washington University School of Medicine and completed his residency and fellowship in PCCM at Johns Hopkins. He's an active researcher in critical care, ARDS, mechanical ventilation, and pragmatic trial design. Thanks for coming on the show today, Kevin.
Yeah, I'm delighted to be here today. I'm also recovering from ATS, but I'm fully recharged.
Nice. Yeah, back to 100%. I love it.
Well, welcome, Kevin. I know we should have asked for your autograph at ATS, but missed opportunities from us. But so delighted to next introduce Dr. Jonathan Casey. John is an assistant professor of medicine for the Division of Allergy, Pulmonary, and Critical Care Medicine at Vanderbilt University Medical Center. He obtained his MD degree from the University of Louisville School of Medicine and completed his residency training in Boston at Brigham and Women's Hospital before going back to Vanderbilt for fellowship training. He is a physician scientist and also has his Master's of Science in Clinical Investigation. His research is focused on comparative effectiveness of ICU treatments, and he also has a focus on pragmatic trials. John has support from the NIH and is active in the American Thoracic Society Critical Care Assembly. Honored to have you on today, John.
Dave and Christina, thanks for having us. We're excited to be here and to talk about our work, and excited to be the very first video presentation. If you're watching the video, then you know why. They invited Kevin to be on screen. He's
Yeah, it's exactly right. We're like, well, we got to go to video now. This is the time.
If I had known that, perhaps I would schedule my haircut before this.
I love it. So just as our standard disclaimer, as a reminder, this podcast is not meant for any specific medical advice. The views we express today may not reflect those of our respective employers, and any cases that we talk about will be HIPAA compliant, but probably we won't be talking about much patient level data today.
Great, Furf. So we're going to get started and excited to kind of open up the question today we're going to be talking about pre-oxygenation techniques prior to intubation for critically ill patients in the emergency departments and the intensive care units. And Kevin, I want to start by defining the scope and nature of this problem and hoping you can tell us, why is this something you were interested in researching?
Yeah, so I think the audience will know that emergency tracheal intubation is really common. Over 1.5 million people are intubated in an emergency department or ICU each year in the United States. Complications from this procedure are also really common. 10 to 20% of patients experience hypoxemia, and 2% experience cardiac arrest. There are very few procedures that internal medicine or pulmonary critical care doctors do where you know that in the next 2 minutes, 1 in 50 patients will die. And so this is a really important question, and it's a really big problem.
Yeah, absolutely. I think that certainly as you get experience, these are procedures that are done commonly and people can do them confidently, but it's probably the most anxiety-provoking procedure that we do, just given the nature and severity of the illness. So a huge topic, important for us to have the optimal strategy. So in this trial, you guys were investigating exactly that, the optimal strategy for pre-oxygenation to try to avoid that peri-intubation hypoxemia and then the more severe consequences like a cardiac arrest. in general, I think pre-oxygenation is a super fun topic that comes up with intubation. I like to talk about it with like the medical students and residents about how much, if you pre-oxygenate, you don't need to breathe, right? So we're paralyzing these patients. But so I always ask them, like, what's the longest someone can hold their breath? And I think the world record now is something around 23 minutes if they allow pre-oxygenation. And you just, if you can do 100% oxygenation, our bodies are very good at this and being able to have quite a big reserve without breathing. However, obviously, our patients in the ICU are not competitive divers who can hold their breath for 23 minutes, and we have a much smaller, narrower window. So, John, before we go and show what you guys investigated, could you just discuss the various methods of pre-oxygenation that have existed before this, their pros and cons, and which are commonly used in the ED and ICU?
Yeah, great question. So the most commonly used methods of pre-oxygenation are face mask oxygen, of which there are several subtypes. So there's a non-rebreather mask or a bag mask device. And those are the most commonly used methods of pre-oxygenation. Those are used in about 70% of patients in global registries. And I think that coming out of the operating room, where you're right, where it's very easy to pre-oxygenate patients, those have been considered by many people to be sufficient. However, as we know, many of our patients are hypoxic even on those devices, and as soon as they become apneic, they rapidly develop hypoxemia. So there's been an interest in using more advanced methods of pre-oxygenation like non-invasive ventilation. That's still only used in about 15% of patients globally, and many of those patients are not used just for the 3-minute pre-oxygenation device, but have been on that device for respiratory support leading up to the point of intubation. The pros and cons of each device, something like a non-rebreather is really easy to set up. It takes very little technical know-how to place a non-rebreather, and there's no risk of any complications like aspiration. A non-invasive ventilation has other potential advantages. So it guarantees 100% oxygen and prevents any entrained air. It provides positive pressure, which can recruit lung, and it also can provide ventilation when a patient's apneic. Now, the potential downside of non-invasive ventilation is this hypothesized risk of gastric insufflation and aspiration. And I think that historically that's been one of the reasons people have been reluctant to use it as pre-oxygenation.
Thanks so much, John, for walking us through that. And first, just going back to your comment about how long you can hold the breath, I feel like one of our ICU teams had a friendly, spirited competition with that. It wasn't 23 minutes. I think maybe the winner was an intern, and it was around 5 minutes. But I anticipate this may be a theme going forward.
Yeah, it's still impressive. 5 minutes. I couldn't do that, even with pre-oxygenation.
Well, John, that was really helpful to kind of hear about the pre-oxygenation methods that we have available. And turning a little bit towards the trial itself, so we previously had some of your colleagues, Matt Semler, as well as Todd and Eddie from the ICU Ed and Toddcast. So we have discussed pragmatic trial design on prior episodes. And we definitely encourage those listening today, if you haven't listened, definitely check those out. John, but wondering if you could tell us a little bit more about what patients were included in this study, as well as any like inclusion, exclusion criteria, and the outcomes and safety points that you had looked at.
Yeah, great. Maybe I'll start with the eligibility criteria and let Kevin take any outcomes. But the eligibility criteria are intended to be broad. So we're trying in these pragmatic trials to enroll a maximally generalizable population. So we try to minimize any exclusion criteria to those that are really framed around safety or federal regulations. So every patient undergoing orotracheal intubation with a laryngoscope and sedation in an ED or ICU participating in the trial was eligible. So basically everybody. The only people who were excluded were those who were children, known to be pregnant or prisoners, patients who were apneic and required immediate ventilation, even in the pre-oxygenation period, or patients for whom the clinicians felt that either a non-rebreather or non-invasive ventilation was required or contraindicated.
That's great. Thanks, John. And then before we even talk about the specifics of the methods, could either of you, John or Kevin, just tell us about, as you were designing it, the primary outcomes you came up with, and then some of the cool secondary exploratory outcomes where you were sort of looking at different levels of hypoxemia, just to set the framework for everyone?
I can certainly talk about the primary outcome, and I'll let John take the secondary exploratory ones. The primary outcome for this trial was hypoxemia, as defined as an oxygen saturation of less than 85%. We chose that value for a number of specific reasons. First is that's on the steep part of the oxygen dissociation curve. So patients with a saturation of 85 are very steep on the hemoglobin oxygen saturation curve and are going to rapidly desaturate further. Additionally, that's a value that has been associated with worse outcomes for patients undergoing intubation. Finally, from a procedural standpoint, that's roughly the recommended point where intubation attempts are aborted and reoxygenation is initiated. From an outcome design standpoint, we had a real choice of whether to have a binary outcome, which is did the person desaturate, yes or no, or a continuous variable outcome of what was the lowest oxygen saturation. And I think we ended up making the right choice of going with the binary primary outcome. It really tells the story more clearly. We actually included lowest oxygen saturation as a secondary outcome, moves in the same direction as the primary, but I think the message is stronger with the binary outcome. John, is there anything you want to add?
Yeah, as Kevin mentioned, this is a very trial wonkish discussion, but people listening to this podcast are probably interested in those kinds of decisions. And if people have followed our work, the PREVENT trial, which is also relevant here, we might talk about later, was a trial where the primary outcome was lowest oxygen saturation as a continuous variable. What was the absolute lowest oxygen saturation? I think we learned a lot of things both in the analysis of that trial and in the reception it received. One of which is that we, in that trial, looked at both lowest oxygen saturation as a continuous and a binary variable, and people weren't as impressed by the continuous variable. So you can imagine that most people don't desaturate, and that when you're looking at a pre-oxygenation device, it might change the median oxygen saturation for all patients from 99 to 96, or it might prevent extreme cases, or hopefully it does both. But although the continuous outcome might be more statistically powerful, if you change the median oxygen saturation from 96% to 99%, that alone is not very impressive or persuasive to people. So although you might be sacrificing statistical power going to a binary variable, that's the variable that we clearly receive feedback was relevant to clinicians, was preventing this dichotomous outcome that they are worried about in their patients, and that's more clinically relevant. Now, if you've decided to go to the binary outcome, you have to decide what threshold to choose. So there's never been a pre-specified threshold that defines hypoxemia. We can look at oxygen dissociation curves to say when does the risk start, and that's where we look to depict the 85% in this trial. But it's clearly true that there are many times, like bronchoscopy, when our patients have momentary desaturations and recover without any ill effects. I think our thought in this is some patients, unfortunately, when they have low oxygen saturations, don't tolerate that and have cardiac arrest. But what threshold should you choose for that to prevent, as the important threshold to prevent? So we chose 85% as the primary outcome, and then, as you mentioned, looked at other more severe thresholds as secondary and exploratory outcomes, like oxygen saturation less than 80% and less than 70%.
Yeah, it's a really interesting conversation. And I also feel like having the binary, at least for me as a reader of it, I mean, it's a pragmatic trial, so it's super applicable to, our broad practice. And having that binary almost feels more applicable too, because if they are intubating and you have your little QRS volume and it starts to go down, it's not like I'm not worried at 85 and I worry at 82. Like I really worry about the fact that we're having that downtrend. And so in some ways, as a reader of it, it makes it very applicable to say, oh, these are the number of patients we're having it. So in looking at a trial like this, obviously the specifics of what you guys did in your intervention can very much inform what the ongoing bedside practice is. So Kevin, I was hoping you could tell us, in more detail, what both pre-oxygenation methods were in each arm of the trial.
Yes. So we had two groups. We had a non-invasive ventilation group and an oxygen mask group. In both groups, we recommended a minimum of 3 minutes of pre-oxygenation. Now, if the patient's condition warranted more immediate intubation, the operators could, but our goal was to provide at least 3 minutes of pre-oxygenation. In the non-invasive group, we required a minimum expiratory pressure of 5 centimeters of water, a minimum inspiratory pressure of 10 centimeters of water, and a set respiratory rate of 10 breaths per minute, as well as delivering 100% oxygen during the pre-oxygenation period. We encouraged clinicians to keep the non-invasive ventilator on after induction of anesthesia until initiation of laryngoscopy. In the oxygen mask group, clinicians could use either a non-rebreather or a bag mask device without positive pressure ventilation during pre-oxygenation. We recommended the maximum flow rate possible, but we encourage people to give at least 15 liters per minute and we encourage continuation of oxygen between induction and initiation of laryngoscopy. In both groups, clinicians could keep on nasal cannula of all forms, including standard bore nasal cannula, as well as heated high flow nasal cannula.
That's great. And on a very specific logistical standpoint, I'm curious how often, if you guys know in the trial or in your own practice from being part of the trial, that the non-invasive device you were using was the same device that then became the ventilator, or if you guys had two devices in the room, which obviously can pose some logistical hurdles while you're doing this in the ICU.
So that's a great question. Our hope during the implementation phase is that people will use this with the equipment that's already available in the room. In the trial, we gave sites the option to do either one, and about a third of patients were intubated at a site that used the invasive ventilator, and about 2/3 at sites that used a dedicated BiPAP machine. So obviously, physiologically, those two devices are equivalent. It's just how you want to train your providers. And I think the idea that people are going to bring in a dedicated machine for 3 minutes is even for an intervention that's pretty beneficial is probably too big an ask. So certainly here, the way we're training our staff and the way that we're asking all the network sites to train their staff during the implementation phase is to make sure they have the equipment and training to use the same ventilator that's already in the room.
Yeah, I think we had the fortunate experience that we underwent the Respironics recall right when we were starting the trial. So when we were launching the trial, we had no dedicated BiPAP machines. We only had invasive mechanical ventilators. And that was actually quite helpful for changing institutional culture. So for the first 2/3 of the trial, we exclusively used the invasive mechanical ventilator for pre-oxygenation. And I think it's the right answer. It's most cost effective and it's very convenient.
Yeah, absolutely. Yeah, I think that it just would help. If that's the training, then nobody is like, oh, I don't want to go get this other device. And it just makes the hurdle so much lower. Oh, thanks for elaborating on that.
And what we did at our site, and what I hope other sites do, is some ventilators, some hospital stock ventilators that can always do this. Our hospital stocks two types of ventilators, one that has a non-invasive mode and one that doesn't. So we would preferentially have one ventilator ready for pre-oxygenation. So the ventilators that could provide non-invasive have a mask just hanging on them, and that's the next one they pull when they're intubating a patient. They pre-oxygenate using that device, and then use that device for invasive mechanical ventilation later, and then always make sure that there's one in the equipment room set up for the next patient to be pre-oxygenated.
That's great.
Yeah, and I just have another quick question as I'm thinking about this. I know, John and Kevin, you're at different institutions, right? And I think with this trial, different institutional practices at some of the team members who, help with the endotracheal intubation may have been a bit surprised, right? You usually just reach for the AMBU bag and bag mask valve, and some people maybe have walked in and be like, what's going on? But how did others kind of perceive this? And were there any, unexpected reactions that y'all had?
So at least locally, and I think in most ICUs, respiratory therapists are key partners in the intubation procedure. I rely very heavily on them. I think most people do. So they're the people who are responsible for setting up the endotracheal tube. That they provide the bag mask ventilation in my institution. And so it was really important to get respiratory therapy buy-in at the start. And I think we mostly achieved that. I do think that the respiratory therapists were appropriately skeptical about a relatively novel intervention for them. So our practice was not to pre-oxygenate with non-invasive prior to this study. So we had very limited experience with that. I think once they got familiar with it, and now that they've seen the outcomes, they're on board. It just they had the appropriate skepticism about changing their practice. I think they're right in having that.
And I'll say it's all about expectations. So I think our site was also a site that didn't routinely do this. Certainly we have a lot of patients who were already on BiPAP and would remain on BiPAP for pre-oxygenation. There are sites that were already routinely doing this, and that's particularly common in international sites like France and Australia that really routinely do this using the same ventilator that they'll use for invasive mechanical ventilation. And once we explained that to our RTs and really educated them on why we wanted to do this trial and why this might be worthwhile, they bought in. So my experience in our ICU is I'd walk in the room thinking I would require a lot of instruction or help, and it was already going. The fellow had already enrolled the patient, and the RT had already set up the mask and was already pre-oxygenating on non-invasive before I even walked in the room. And I hope that other sites similarly find that if you incorporate this into your usual practice, there are a lot of things during the intubation setup that require more time and energy than does placing a patient on non-invasive ventilation. And it was very easy to do that for 3 minutes during the setup for other parts of the procedure.
Yeah, such a great point. Well, thank you both for kind of sharing your perspective on that. And so you said, pragmatic trial design, enrolling adults 18 years old and older, but wanted to hear, Kevin, from you a little bit more about kind of the group of patients that ended up being recruited as well as the randomization. And is there anything you want to highlight about the cohorts or the intubation procedures itself?
Yeah, I think what I want to just talk briefly about the background. So all prior trials in this space were limited to the ICU and only in patients with acute hypoxemic respiratory failure. They were small trials and they were not definitive. What PREOXI did was we enrolled in both emergency departments and ICUs. And as John alluded to, we had very broad eligibility criteria. So we were enrolling any patient who was critical and needed to be intubated, not just with acute hypoxic respiratory failure. The cohorts turned out to be very sick. Roughly 70% were in the ICU at the time of intubation. A quarter were on high-flow nasal cannula prior to intubation. A quarter were on vasopressors at the time of intubation. The most common medical condition active during intubation was altered mental status. But the groups were similar, just very ill, very broad, critically ill populations.
Yeah. So go ahead, John. Sorry about that.
I think one part of the question you might be asking is this population representative of who we intubate, and did they exclude any high-risk patients? And I think that's always something to think about as you look at the consort diagram. So Kevin can correct me on the number, but something like 20% of screened patients were excluded for urgency of intubation. And that's not, I think this is something that takes time to set up. We worried what proportion of patients would be excluded for urgency, and is there going to be a large group of patients that you can't deliver this intervention in? And thankfully, we found that no, the vast majority of patients, even emergent intubations, they could place the non-invasive machine. And that exclusion rate's not dissimilar to the exclusion rate we've seen in other interventions that take no time to set up, like our recently completed device trial of video versus direct laryngoscopy. You wouldn't expect a lot of patients to be excluded for urgency in that trial, but because it takes some time to get trial materials, to go get an envelope, to find someone to record, even for a device that doesn't require setup time, you can still be excluded from the trial because the trial procedures require time. And the proportion of patients excluded in device was not that dissimilar from in PREOXI. So it wasn't that the intervention took so much time to set up that we were missing emergent intubations, which had been a concern of ours going in, and I think thankfully didn't occur. I think another question is, did we exclude people who were at high risk of the safety outcome? So there were people who were excluded for active emesis or hematemesis, and I think if people are actively vomiting, you really shouldn't be placing a mask on them. But the trial did enroll really a large group of people who were at high risk for aspiration, a lot of people with active upper GI bleeding, people who had recently taken oral intake. So I think this trial, we believe, enrolled the populations that we wanted to, which is the people who were really sick, people who needed to be intubated emergently, and the people who were at risk for aspiration.
Yeah, that's great. And thank you for pointing all those things out, right? Because to your point, sort of makes sense that if someone is actively having emesis or hemoptysis, you can't put a mask on them. But it doesn't mean that the patients you were doing this in were not high risk for aspiration based on all the other risk factors that we know go into intubation. Well, now that we have a good sense of what the trial was and who the patients who ended up in the trial are, John, can you walk us through what you guys found?
Yeah, happy to. So as a reminder, the primary outcome was incidence of hypoxemia defined as an oxygen saturation less than 85% between induction of anesthesia and 2 minutes after intubation. And that occurred at 18.5% of patients in the oxygen mask group, 118 patients. And by comparison, it occurred in 57 patients, 9.1%. So an absolute risk reduction of 9.4%. And a p-value of less than 0.001 and a relative risk reduction of greater than 50%.
Yeah, pretty convincing, clear that we have a reduction in the incidence that we're going to have of hypoxemia overall during this. And I was hoping you could go a little bit more into some of the severe hypoxemia and cardiac arrest, mostly because I think that we know that having hypoxemia during intubation is a risk factor for all these untoward downstream outcomes. That being said, I think when you're reading this, what you care about is how the patient did after the procedure and came through. And I'm curious what kind of signals you saw in those outcomes.
Yeah, so as we've already talked about, this threshold of 85% was somewhat arbitrary. So we had physiologic reasons for choosing it, but I recognize that you could have chosen other thresholds. So we looked at other thresholds like oxygen saturation less than 80% and less than 70%. And we found basically the same signal at every threshold. So at every threshold of hypoxemia, we reduced hypoxemia by more than half. And for example, the most severe cases, oxygen saturation less than 70%, occurred in 5.7% of patients in the oxygen mask group and 2.4% in the non-invasive ventilation group. And as you're alluding to, the question is, does that matter for patients? So this has been an outcome that's been used in many prior tracheal intubation trials, and that it's chosen as an outcome because it's closely linked in observational studies with the most worrisome outcome of tracheal intubation, cardiac arrest. But that doesn't prove that preventing hypoxemia will also prevent cardiac arrest. Maybe it's just that really sick patients experience hypoxemia and the same patients experience cardiac arrest for other reasons. So I think in our prior trials, we've been reluctant to choose cardiac arrest as an outcome because even though it occurs in up to 3% of patients, it would require an extremely large trial, tens of thousands of patients, to be powered for that rare outcome. What we were pleasantly surprised to find in this trial is that by preventing hypoxemia, it appeared that we also prevented cardiac arrest. So cardiac arrest occurred in 7 patients in the face mask oxygen group compared to 1 patient in the non-invasive ventilation group, a difference that was significant with a p-value of 0.04. So I think that does a couple things. One is it proves the importance of this outcome. So I think this is the first trial that now really shows that hypoxemia is an important surrogate outcome during tracheal intubation. And if you can prevent hypoxemia, you should prevent cardiac arrest and save lives. And further, for this specific intervention, it shows that non-invasive ventilation really has significant benefits. So not only does it prevent the outcome that we as clinicians care about, hypoxemia, it prevents an outcome that both clinicians and patients care a lot about, which is cardiac arrest.
Yeah, definitely some very compelling evidence and outcomes there, John. And just to extend on one of the outcomes, Kevin, anything that you want to add about the aspiration safety outcomes? I know we've talked about that risk a few times already during the show, but wanted to see if you wanted to add anything.
That's right. I think I think a lot of what drives clinicians' behaviors about in the intubation procedure is fear of aspiration. We don't know what's in the patient's stomach a lot of the time. Often they are not fasting, and that really guides decisions both during the pre-oxygenation phase and also after induction laryngoscopy, the decision whether or not to deliver positive pressure ventilation. We really focused the design on trying to capture aspiration. So we had a number of exploratory and safety outcomes that were focused on it. The first was operator-reported aspiration. So at the end of the procedure, the person doing the airway wrote down whether the patient experienced aspiration during the procedure. Additional safety outcomes were new infiltrates on chest imaging after intubation, oxygen saturation at 24 hours, and a fraction of inspired oxygen at 24 hours. There was no statistical difference between any of the groups, between the groups on any of those outcomes, suggesting that there was no risk of aspiration. And in fact, there were numerically fewer aspirations in the non-invasive ventilation group than the oxygen mask group. This is a really important finding because I think this should really encourage clinicians to reevaluate their risk-benefit analysis of positive pressure during pre-oxygenation, positive pressure after induction of laryngoscopy in their decision-making. I would point out that Dr. Casey is the first author on the PREVENT trial, which looked at positive pressure ventilation after induction, comparing bag mask ventilation to canonical rapid sequence intubation. And they also found no association between receipt of positive pressure ventilation and aspiration. So for me, my takeaway is that non-invasive ventilation, positive pressure ventilation, does not appear to be a substantial risk for aspiration during intubation. If the risk is there, it's very, very small, and it's clearly outweighed by the benefits of preventing hypoxemia.
And I think if I may, I'll just jump in and say that I think one question, this is a very strong held view by clinicians. So how do we get to this strong held view that positive pressure ventilation isn't safe after you give a neuromuscular blocker? And it's been one of the fun parts of research like this to dig into the data and say, where does that come from? And the answer is that the concern was raised in the 1950s when we started doing tracheal intubation for the first time. And the data that they gathered at that time was pretty poor. So they took healthy volunteers to the operating room and paralyzed them and said, how hard do we have to squeeze the bag before we can hear air in their stomach? And the answer was, in even some of those studies, they suggested that it never or rarely occurred. And some of those studies, they established thresholds that it could occur that might occur in normal bagging. And that led to people saying, well, maybe we shouldn't do this. Those are pretty poor surrogates for what's happening in clinical care. And I think the other relationship that has maybe convinced people is that when do we bag people? So if we don't bag them prophylactically, we only bag them when things are going poorly. And so what is it about intubations where things are going poorly that leads to increased rates of aspiration? Is it actually bagging, or is it the fact that we still have a laryngoscope in their throat at 5 minutes when the sedation might be wearing off? So I think people have these relationships that are perhaps not based in very strong science. So we now have 4 trials, as Kevin mentioned, our prior PREVENT trial, the PREOXI trial, and the 2 prior small trials in non-invasive ventilation that Kevin mentioned from France that were conducted by Biolard and group. And all 4 of those trials have looked at positive pressure ventilation after induction and have looked at aspiration as a primary safety outcome. And in none of those trials has there been any signal for increased aspiration. So I think that should be pretty reassuring that during tracheal intubation, a short period of prophylactic positive pressure ventilation at normal pressures doesn't increase the risk of aspiration. Or even if it does, you could say, well, these are rare events, and altogether these trials have only enrolled several thousand patients. If there is any difference, it's very small, and the rate of that difference is dramatically smaller than the benefit you see from hypoxemia. So I hope this trial and the body of evidence that's building makes people really reevaluate those traditionally held beliefs.
Yeah, and I wonder if the fact that you had the patients that you mentioned that were excluded just sort of tells people that you can basically, based on your best clinical judgment, put yourself in this risk that's very low, right? You're basically excluding these extremely high risk patients, and these were just based on clinicians' bedside clinical judgment. And so once you've taken them out, then you can feel really confident that you're not going to have aspiration, even though that there's this theoretical risk that you mentioned.
Can I push back a little bit on that?
Please.
Sure.
Maybe we don't. Maybe we should include them next time, and maybe there's still no aspiration risk.
I think what John's statement was right, that someone who has vomit in their mouth should not be placed on a non-invasive ventilator. But I just don't think clinicians are that good at predicting outcomes. And so I don't think we excluded high-risk patients inappropriate, or I don't think we were so good at assessing risk for aspiration that we were able to identify those who were at high risk and exclude them. Or if we were, this would be the only condition where clinicians are that good. And certainly I'm not that good. So I just think that this is probably not a physiological relationship between positive pressure after induction and aspiration.
And Kevin's sensitive to that because this was the takeaway from the PREVENT trial. So we had similar findings in the PREVENT trial, and if you go to up to date today, they recommend that you should only bag people who are high risk for the outcome and low risk for aspiration. And I disagree with that. That's not the way we did the trial. We tried to include everybody. And we always want to allow clinicians to do what they think is right for their patients. And we agree that you shouldn't put a mask on people who are actively vomiting. And there may be some clinicians who participated in the trial who excluded people who are high risk, but many clinicians included all their patients who weren't actively vomiting. Like myself, I didn't exclude a single patient for risk of aspiration. And those patients are well represented in this trial, and there's no evidence that there's any increased risk. So I think clinicians should think about how they operationalize this. I agree that a patient who's actively vomiting, maybe even one who's hiccuping, looks shady, you might think about not placing this mask on. But I think the vast majority of patients should be getting this intervention. And it's not as if you should be assessing risk factors for aspiration and then excluding patients from this intervention. That's not the way we did the trial, and that's not the population I think this should apply to.
That's great. Thank you for pointing it out. No, I appreciate the pushing back on it. I think that's super helpful to think about, because when you're reading it and then you're going to take it to your bedside, then you can feel more confident. I love that. I did have one more question too, and this may be a difficult question about the data, to analyze through the data, but I'm curious. I know that you guys have also done prior trials on first pass success and UD video versus direct laryngoscopy. I'm curious if, not that there was a difference between the two groups. I know from your supplement that they had good first pass success in both groups, but if the patients who had hypoxemia, especially that severe hypoxemia, had longer durations or more times where they didn't have first pass success. I'm just thinking about my own experience. Like when that patient starts getting hypoxemic, that's when everyone starts getting nervous. And that's when things kind of start getting a little more chaotic during the intubation procedure. And I'm curious if you guys saw any signal like that. It may have been too difficult to weed out those very specifics.
So it's definitely true that when you fail on your first attempt, you're at increased risk for all kinds of bad outcomes, including hypoxemia. And so an intervention like this might be more protective against cases like that. The challenge is you don't know going in who you're going to fail in. So that's what we call a post-randomization variable. So we tend not to look at a lot of analyses like that because you should make decisions about how you treat patients based on what's knowable at the time you have to make that decision. And I don't know when I'm deciding pre-oxygenation device if I'm going to fail or not. So I better do the thing that gives me the best chance whether or not I fail. So that's one answer. The second is that we do look at this and say, are these outcomes occurring only in patients who had failure in the first attempt or not? And the answer is, even though when you fail on the first attempt, you have a higher risk of hypoxemia, that's the minority of patients. We succeed in the first attempt in 85% of patients. So most events of hypoxemia are occurring in people who we successfully intubate in the first attempt. So we did everything right. We did everything perfectly well. We had a short and successful intubation, and the patients still experienced hypoxemia. And so those patients also benefit. So I think this also comes up when you talk about operator experience. So this intervention may be even more beneficial for an inexperienced operator who's likely to take longer to intubate and expose their patient to a longer period of apnea. But it's also beneficial for very experienced operators who are likely to intubate their patient on the first attempt.
That's great.
Yeah, it's so great. I was just thinking, I was like, if there's not a little bit of pushback from Kevin Gibbs, is it really Kevin? So thank you. And just, I think, having us think of different perspectives. I think one other question Furf and I were also just thinking about too was just the use of high flow nasal cannula for pre-oxygenation. It looks like there were some people on high flow nasal cannula prior to the intubation and then underwent intubation per the trial protocol. We're both wondering if you want to share any thoughts of incorporating high flow nasal cannula into trial methods in the future, or anything that you want to share about that.
Yeah, I think consideration of high flow nasal cannula is really important for contextualizing PREOXI. The first comment I have is that PREOXI does not inform the use of high flow nasal cannula for pre-oxygenation. It was allowed in both groups. It occurred more commonly in the oxygen mask group than the non-invasive group, but we specifically didn't analyze whether that impacted the rates of hypoxemia in the study. On a personal level, I'm a little skeptical about using high flow nasal cannula as a pre-oxygenation strategy. This has been studied, and the data is quite mixed. In some studies, it's equivalent to non-invasive. In some studies, it's not. In some studies, it's not better than an oxygen mask. What is true is that high flow nasal cannula does not provide positive pressure ventilation after induction anesthesia. And so all the benefits that you experience with positive pressure after induction are not delivered by high flow nasal cannula. From a practical standpoint, many ventilators are capable of delivering high flow nasal cannula, but not all. And certainly no ventilators are capable of delivering both non-invasive ventilation and high flow nasal cannula simultaneously. So you're really confronted with the choice of which of these interventions are you going to use for your pre-oxygenation strategy. From my standpoint, we have robust data that non-invasive ventilation is superior to oxygen masks and decreases the risk of cardiac arrest during intubation. And so that's the strategy that I would choose. I don't think it's really practical to wheel in a high flow nasal cannula and set that up, and then for 3 minutes when you could just connect the non-invasive ventilator to the machine, non-invasive mask to the machine, and deliver non-invasive ventilation. John, do you have additional opinions on that?
Yeah, you can tell that this is something that we've talked a lot about and thought a lot about during the design phase, and even in the short time it's been published, have been asked a lot about. And just to explain our kind of rationale for why it wasn't either mandated or as part of the control intervention or included as a third arm. The first is that it's not used very commonly. So if you look at national international registries and you look at the data from our prior network, in the NTube study, for example, which is the best international registry on tracheal intubation practices, high flow nasal cannula as pre-oxygenation is only used in 8% of patients. So it's not being done very commonly now. The advantage of high flow nasal cannula, even over a device like non-invasive ventilation, is that during the time that you're performing tracheal intubation and the laryngoscope's in the mouth, you can still have this high flow nasal cannula in place and maybe be delivering oxygen through diffusion even when the patient's apneic, so-called apneic oxygenation. That potential benefit really excited a lot of people and appears, unfortunately, to have been overblown. So now there have been a lot of trials looking at apneic oxygenation that have shown no benefit or a small benefit, and trials that have looked at high flow nasal cannula compared to face mask, as Kevin mentioned, have not shown a difference, maybe differences in some subgroups like patients with severe hypoxemia, but no benefits overall. And then there's a trial that directly compared high flow nasal cannula and non-invasive ventilation, the FLORA-LEAD-2 trial, and that hoped to find a benefit of high flow nasal cannula, and found that not only was it not better than non-invasive ventilation actually appeared superior in patients who were high risk. So looking at that body of evidence, we felt like if you're going to bring a special device in the room, and I think it is important to note that many ventilators can deliver either high flow or non-invasive, but not both, as Kevin mentioned. So if you're going to bring that device in the room, you should probably bring in you should bring the device that's most likely to have benefit, and that's why we chose to compare non-invasive, the strategy that had the best preliminary evidence, against the strategy that people were actually using, which is a non-rebreather or a bag mask device. So I think high flow nasal cannula is something that I think people will continue to ask about, and maybe additional evidence will accrue. But I personally believe that the preliminary evidence suggests that there's that it's not certainly not better than, and probably not as good as non-invasive ventilation.
Great. And then for any, just anything, I don't think any other questions, probably starting to wrap up. Are you cool with that?
Yeah, I think going wrap is great. This has been awesome.
Great. So thank you, Kevin and John, for walking us through that. And you've already talked and alluded to several of the main takeaways from this trial. And I haven't attended in the ICU since the results have come out. But just a quick question. I'm just interested I don't know if you have, or Kevin and John, how has your day-to-day personal practice changed from these results?
Yes, go ahead. So I've been in the ICU, and part of the reason I asked about the logistical thing is that our RTs right now are not super used to using the ventilators for non-invasive. The ventilators do work for non-invasive, and so we have the ability to do this. And so I think it's very much that partnership and education phase that Kevin and John talked about. I don't think anyone is opposed to it, and I think as we review the data more, we'll do it. But right now, it still involves that second machine, and that I think is the logistical barrier. But actually, at an upcoming meeting of everybody, we're going to be talking about PREOXI, and hopefully that gives people enough good confidence and excitement to then start using the machine as it actually is designed and can be used very well.
For me, I think the most striking thing about this trial, and the thing that I was not prepared for, was that non-invasive ventilation benefited all subgroups. And so even patients who were not hypoxemic, or who I would not classify for being at high risk for desaturations during intubation, had less hypoxemia when they received non-invasive ventilation. So patients who were on room air, who did not have a diagnosis of hypoxic respiratory failure, had a lower incidence of hypoxemia when they were pre-oxygenated with non-invasive. And that's really powerful for me. We're reducing the risk of bad outcomes even in patients who were at low risk for hypoxemia. And so my practice has been to adopt this broadly. Essentially, any patient I am intubating will receive non-invasive pre-oxygenation.
John, anything you want to add? Sorry.
Yeah, I totally agree with Kevin. So I think if you'd asked us in our heart of hearts as investigators what we would find, I think there was a range of opinions within the group, and we actually evaluated that before we showed the group the results. And there were a fair number of people within the network who didn't think it would be beneficial at all. And there were others who thought, I would say the majority opinion might have been that it would only be effective amongst those who were high risk. And I think that's probably where I landed. I thought this was going to work, but the benefit was going to be largely or all in people who were high risk, who were already on a lot of oxygen, who were being intubated for respiratory failure. And we found that the effect was really consistent across all subgroups. As Kevin mentioned, even people who were being intubated for ultramental status, even people who were on room air at the time you made the decision to intubate, even amongst those people, you cut in half the risk of hypoxemia. So I think that's really changed the way that we have approached the implementation at our own site. As Dave mentioned, it takes effort. So we put a lot of effort in during the trial to make sure we could deliver this intervention well. And then the trial ended, and we didn't know the results yet, and we fell out of the habit, if I'm being honest. So now that I'm back on, I ask for it, and it has not. If I don't ask for it, it doesn't happen. And now we are intentionally now that the trial results are public, intentionally implementing this in a very systematic way. So I hope that going forward, every patient intubated in my ICU will receive this. But it's not going to happen on its own. It's not going to happen through word of mouth. It's going to take interfacing with the RTs and a really intentional approach to implementing the intervention.
That's great. John, the only thing that I think that you meant to say was that instead of your heart of heart, you meant your lung of lungs, right? Is where everyone felt like this was going to happen.
You got it.
Well, this has been an awesome discussion. Thank you guys so much for conducting the trial, for the great work that you're doing, and then for coming on the show to talk about it. And we hope that everybody's enjoyed listening. If you guys are listening now, please make sure you rate, subscribe, give us 5 stars wherever you're listening, and join us back in 2 weeks for our next episode. This episode was written, edited, and produced by myself and Christina Montemayor. The original music by Eric Rogers, and we'll see you next time.